Okay, this is an educational video on the most common overuse finger injury in a climber called tenosynovitis. Another term that we can use to describe some of the pathophysiology of tenosynovitis is tendinitis, because there is often a tendon component which is harder to diagnose and not commonly talked about, but also a membrane irritation of the tendon sheath, creating an inflammatory response that is in and around the pulleys, which can oftentimes mimic a pulley injury. So other names for this is tendinitis or tenovaginitis, which refers to the membrane around the tendon sheath. It's essentially an inflammatory response of that flexor tendon sheath. As mentioned already, this is the most common overuse injury in a climber's finger, brought on by a lot of excessive climbing volume. So, as already mentioned, mimics a pulley sprain relatively commonly. Etiology here: repetitive high stress in a half and a full crimp position. So as we grab on with the finger and we put a lot of pressure in a 90-degree joint angle, or more acutely, we put a lot of pressure of the tendon up against the pulleys and the tendon sheath, and as a consequence of opening and closing and twisting over many climbing moves over many days and months, we get an irritation of the membrane, creating this inflammatory response. This happens most commonly between the A2 and the A4 pulleys, so it happens across the PIP joint as a result of increased flexion with PIP joint flexion. So if we look at this picture here, this is a GIF that we're not going to watch the video of, but the location of primary friction happens across the edge of the A4 pulley, across the edge of the A2 pulley, and across the A3 pulley. Overload here leads to an inflamed sheath. So one thing that happens as a climber, we climb for a long time, we get size changes to the annular pulleys, increased size. We also get size changes, increase to the tendons themselves. As a consequence, the fibrous tunnel, or the fibroosseous tunnel that the tendons pass through, becomes a little bit tighter. So if I have a little bit cross-sectional area in my tendon, and I have an increased cross-sectional area in my pulley and stiffness in my pulley, I essentially make a tighter space for the tendon to run through, creating the increased friction, creating the inflammatory response. A lot of times this accompanies degenerated tendons, which is also something that's not well reported in climbing, not easy to see on an ultrasound scan, sometimes needing an MRI for that diagnosis. It's a consequence of frequent cumulative micro trauma, and also reduces healing time. So we put a lot of pressure on the tendons in the tendon sheath, reducing the blood flow, thus making it harder for the inflammatory material to leave after a lot of chronic loading. Excessive climbing is the primary mechanism. If we're climbing a lot, if we're finger training, if we're strength training where we're grabbing pull-up bars, deadlifting, etc., we just increase and amplify the mechanical pressure of the tendon against the tendon sheath, maybe creating a little bit more susceptibility to tenosynovitis, certainly enough pressure to keep the symptoms around long term. If we look at a diagnostic ultrasound here, here's an image of an A4 pulley tenosynovitis with some cystic changes that are happening. So right in the middle, here's the tendon, that's the FDP tendon. This is the middle phalanx right here, so middle phalanx. The tip of the finger is to the right, so it's looking down here, let's say on an index finger, tip of the finger is to the right, proximal phalanx or A2 pulleys to the left. The A4 pulley is in this area right here, and then all of this is fluid. So as a consequence of a lot of grabbing and squeezing and opening and closing over long periods of time, we get enough friction on the undersurface, creating an inflammatory response, get a little tear in the tendon sheath, and that's where we get the fluid accumulation that lives in and around the A4, the A3, and the A2 pulleys. If we look at this picture down low, we can get another appreciation of the primary mechanism. So here, the pressure in the tendon as the finger flexes, there's pressure on the undersurface of the tendon against this primary location of stress across the joint. So if I'm constantly grabbing on, swinging, opening, closing, I'm just taking the tendon and I'm rubbing it on the undersurface of the tendon sheath and the pulleys, leading to an inflammatory response that creates this etiology. I kind of attribute it, or I guess make it akin to pulling your rope, your climbing rope, over the edge of a cliff. So if I'm grabbing onto my rope and I'm pulling my rope over the edge of a cliff and it's back and forth and back and forth, the outside membrane of the rope sheath will create little friction tears. Sometimes it can expose the fibers underneath, which is kind of a red flag for a climbing rope. You won't ever expose the tendons like that, but the analogy kind of works, whereas if there was inside the rope, there was fluid, that fluid would kind of leak out because of the tear in the sheath. Kind of the same thing happens with tenosynovitis. It's very common that tenosynovitis will accompany a cyst. It's also common that tenosynovitis will lead to or precede a pulley strain or pulley rupture. So this is one of those pathologies that is very common in climbers, but it also leads to other things. So we want to make sure we manage climbing volume first, more than we need to do easier climbing volume, because easier climbing volume also produces stress on the annular pulleys and the tendon sheath, but it also has something that pushes back. So in the context of climbing on jugs or doing pulling, we get pushing back of the object against the tendon sheath, and we still get the sliding. This is not exclusively a climbing injury. Pulley ruptures are almost exclusively a climbing injury. Growth plate fractures to youth athletes is an exclusive climbing injury, but tenosynovitis happens in CrossFit athletes and jiu-jitsu athletes, people that do a lot of grabbing and squeezing heavy objects for a high amount of volume. If we look at here, the clinical picture, this is pain that can extend into the palm or the forearm or the tip of the finger. So if I have pain over the joint, maybe at the A4, the A2, and the pain spreads to the tip or spreads into the palm, pretty common with tenosynovitis. The tendon sheath, the membrane, lives here in the palm and extends the length of the finger. So one of the mechanisms by which we can reduce tenosynovitis in cases that don't respond to conservative therapy is we can order injections into the tendon sheath with steroid to help reduce the inflammatory response within the membrane. So it's common to have movement of symptoms up and down the finger with tenosynovitis. That's not as common with a pulley strain or rupture. That's not common with cystic changes. That's not common with capsulitis. So make sure that you pay attention to the movement of the symptoms, whether they're going distal, which is further away, or proximal, more towards the palm. Sometimes we can have minor swelling along the palmar surface of the finger. So sometimes you'll feel puffiness here, and it'll feel more puffy along the length of the finger. That's very consistent with an advanced case of tenosynovitis. You will get some point tenderness at the level of the inflammation, and the inflammatory response happens across mostly those primary joints. So again, if we look at the primary pulleys where tenosynovitis stress happens, it is from the A2 to the A4 pulley. Maybe that's a bad color. From the A2, that's the worst color, sorry. A2 to the A4 pulley across this area. So it'll often feel like an A2 pulley strain, but it'll also be like it kind of moves to the A4 pulley, so across the joint. Very common with tenosynovitis. Diagnostic ultrasound is a very good diagnostic tool to understand the extent of the tenosynovitis, to also understand if there's underlying pulley strains, also understand if there's underlying joint effusion and capsulitis inside the joint. If you have enough climbing volume and enough training and climbing volume to create tenosynovitis, it's likely or not uncommon to have some pulley strain, to have some joint effusion, to have some arthritic change, etc. But the halo presentation that we see around the tendon, within the tendon sheath, is the diagnostic objective marker that we're looking for with an ultrasound machine. So this is increased fluid visible in the short and the long axis. And then we want to compare the ultrasound with the opposite hand. So if we look here on the ultrasound here, here's a short axis ultrasound. Here's a bone. Here's the FDP tendon. Just put tendon. And then the A4 pulley is here on top. Quite small. Not much fluid on the sides. If we look at the pathologic side, it's easy to see that here's the bone, here's the tendon, and there's an increased size here, and there's also an increased fluid on the side. If we look at the long axis view, which we already did here, this is the same athlete, we can see here there would be increased fluid around here, and then if we scanned more proximally on the hand, we would see fluid that's accumulated over the A3 pulley and maybe into the A2 pulley. That's not as common with most people with tenosynovitis, but it's something I see relatively common. That wouldn't be the same as assist change. Assist would be more localized pressure, localized swelling, a little pocket of fluid, where with tenosynovitis, we're going to see more spread of the fluid along the finger. In terms of treatment, anti-inflammatory medications is a common treatment modality. Using oral anti-inflammatories for a 7 to 10 day dose works well, ibuprofen, diclofenac, etc. We can also rest. Sometimes we need to splint this. So sometimes bending the finger in any capacity is quite troubling on the finger. In that case, we need to get rid of that repetitive flexion of the finger at the same time using an anti-inflammatory strategy to help calm down the symptoms. Other things you can do massage, ice therapy, gentle loading, just to keep fluid movement. That's where tendon glides maybe would come in. But I caution people to do too much tendon gliding, meaning like multiple times per day, all day, because that could be a source of irritation. But a little bit of gentle motion makes sense. Icing, ice the hand, let it thaw. Ice the hand, let it thaw works, or contrast bathing, ice the hand, heat. Ice the hand, heat. The function of those methodologies or those treatment strategies are to increase perfusion. So we want to get blood to and away, and we want to create a vasodilation, which is fluid to, and a vasoconstriction, which is fluid away, in the hopes that we can help reduce the inflammatory response without adding a lot of mechanical stress to the finger. H-taping the finger is something that we would use when we get back to climbing. So when you get back to regular climbing, H-taping the finger restricts the range of motion a little bit, but it also helps support the sling so there's not as much downward pressure of the tendon against the pulleys. Cortisone injections are quite helpful in my opinion for advanced cases that don't respond to conservative therapy. In that case, we would refer out and you would get a tendon sheath injection at a couple locations, helping reduce the inflammatory response very quickly. Because this is the most common overuse climbing injury, it's important to note that these overuse injuries happened over weeks to months to years of time. That means it's going to take probably 8 to 12 weeks to get this to calm down if we can manage it and catch it quickly. I typically refer athletes or suggest athletes book the 8 or 12 week plan to make sure we can deload the tissue, we need to unload it, we need to reduce the inflammation or manage it, then we need to reload, then we need to progressively load, and then we need to get back to full climbing performance. But it's certainly going to take more than a week. Certainly going to take more than a month. So you have to be patient with this. If you're someone that's been dealing with this for a while and you're going on a climbing trip next week, you can't expect a lot of symptom resolution in that week of time. You're better off going on your climbing trip, and then when you get home, dedicate a 3-month block where we can really get the symptoms under control. Okay. Other thing, this just shows like the injection suggestions and the material that would be used for the injections. Additional management strategies. Sometimes you'll have bone spurs that accompany tenosynovitis with a lot of stress. I don't see those very often. Radial shockwave therapy is something that people do to manage pain. I would say the radial shockwave therapy is really only reserved for bone spurs. So if you have a bone spur growth, you might need to use a shockwave to break that up. Sometimes they need to go in there surgically and excise those, but that's not the common case. The common case with tenosynovitis is going to be athletes that are doing a lot of climbing volume, that do a lot of board climbing or intense crimp climbing volume, also doing finger training, and in addition to that, strength training. So it's really the culmination of all of those things that put a lot of pressure on the tendon up against the tendon sheath over long periods of time that create tenosynovitis. So in order to manage this, you can't just do easy climbing volume, because easy climbing usually has more volume because it's easier, but grabbing onto jugs can be quite provocative, because as this picture shows, we're pulling down of the tendon on the tendon sheath and the pulleys, but we're also pushing back. So we pin the pulley and the tendon sheath against the object, and then we still get some of that sliding, only exaggerating the symptoms. So making sure you get the right diagnosis is really important. For people that come into my office, we ultrasound scan these every single time. For follow-up appointments, we will rescan them to ensure that we're getting the swelling to calm down. And then we need to start from an unloading process, and then we need to slowly over time build that tolerance back up. The general trajectory that I think about on the finger for those athletes is we start open-handed, we need to slowly get into a half crimp position, more aggressive, and then we need to start doing full crimping. That's pretty easy to do if we take the right strategy and we get away from the climbing intensity and we get away from easy climbing volume. I find too often that if athletes do too much easy climbing volume, It doesn't really make these worse necessarily, but it definitely maintains symptoms to stick around for far too long.